Hello, my name is Dr. Olutayo with Breast Surgical Oncology. I will be presenting to you today on breast disease. This is part one, the disease overview. We will discuss the anatomy, benign breast disease, malignant breast disease, and types of breast surgery. Then we'll proceed to part two. The anatomy of the breast. The breast is composed of fat, lobules, and ducts, as well as suspensory ligaments. Venous drainage of the breast is by the internal thoracic vein and the lateral thoracic vein. Blood supply are from branches of the internal thoracic artery, the thoracoacromial, the lateral thoracic, and the intercostal arteries. Here you can see an image depicting the anatomy, the ribs, pectoralis muscle, as well as the ducts and lobules. The surgical borders of the breast, particularly important in a mastectomy, are superiorly the clavicle, the inframammary folds inferiorly, the sternum, and the latissimus dorsi laterally. Associated nerves, these are very important anatomical structures to take note of. The long thoracic nerve innervates the serratus anterior. Injury to this causes winged scapula. The thoracodorsal nerve innervates the latissimus dorsi. Injury to this causes weak arm pull-ups and a deduction. The medial pectoral nerve is one that innervates the pectoralis major and minor. The lateral pectoral nerve innervates the pectoralis major. An easy way to remember that is medial does more. The intercostal brachial nerve innervates the medial arm and the axilla. It's the most commonly injured nerve during axillary or breast surgery. Here is an image depicting the venous and arterial supply to the breast. You can see the thoracic wall has multiple arterial and venous structures that are important to note. The ones that supply the breast were just previously mentioned. You can also see the relationship of the thoracodorsal and the long thoracic nerve in the axilla. It's very important to note their orientation and their location. The thoracodorsal is here, and the long thoracic is here. Here is an image depicting the anatomy really in the axillary region. Here you can see this is the main aspect of the patient's body. So this is medial. This is the superior part of the patient, so the head, and this is inferior. So here you have the axillary vein. You have the thoracodorsal bundle. As you note, a bundle travels usually in three when we talk about anatomical structures. So that is the nerve, vein, and artery traveling together. And so here is the thoracodorsal nerve traveling with the rest of the bundle. Here you can see the long thoracic nerve. And here's the serratus and latissimus dorsi. Lymphatic drainage is mostly to the axillary nodes, about 97% of the time. You can also have drainage to the internal mammary nodes, the supraclavicular, and the cervical nodes. So it's important to pay attention to these areas during your physical exam. Axillary node dissection involves identifying the different borders and aspects of the axilla. So you want to look for the axillary vein that we discussed, the chest wall, the latissimus dorsi, and the lateral skin flap, the pectoralis minor, and the latissimus dorsi wrapping around posteriorly. The axillary lymph nodes have three levels: 1, 2, and 3. Level 1 is lateral to the pectoralis minor. Level 2 is deep to the pectoralis minor. And level 3 is medial to the pectoralis minor. You can see them here: 1, 2, and 3. Now, it's important to know that when you have nodes between the pectoralis major and minor, we refer to those as Rotter's nodes. Now, when we talk about physiology of the breast, it's important to know that estrogen, progesterone, and prolactin are the three important hormones. Estrogen allows for duct development, growth of glandular tissue, and causes breast swelling. Progesterone leads to lobule development as well as maturation of glandular tissue, and prolactin helps with milk production. So, let's talk about some benign breast diseases. We'll break them up into infectious, non-proliferative, and proliferative. Let's first talk about infectious mastitis. Infectious mastitis is most commonly caused by Staphylococcus aureus and is usually seen in patients who are breastfeeding. Usually, we recommend that the patient continues breastfeeding. Now, mastitis can progress to abscess, so it's important to continue with physical exams and follow-ups with these patients. The abscess is also most commonly caused by Staph aureus and also seen in breastfeeding patients. Usually, we recommend the patient continue breastfeeding unless it is absolutely too painful and is causing distress for the mother and child. Then we do recommend stopping and reassessing. Usually, we treat this with antibiotics and sometimes an incision and drainage, and occasionally an aspiration can be suffice. This is usually for smaller abscesses. Different sources will tell you different numbers to reference. Some will say 5 centimeters, and some will say as small as 3 centimeters. So, using clinical judgment is important. The big thing to recognize is if there's overlying skin involvement, usually an incision and drainage is going to be your best bet. If there's no overlying skin involvement, usually aspiration for smaller ones can be successful. Periductal mastitis or ductectasia is usually seen in non lactating women. It's associated with smoking and diabetes, and it has mixed infections of aerobic and anaerobic skin flora. It tends to be recurrent and causes scarring and can lead to nipple changes and fistulas. It usually can be treated with IND and antibiotics, and recurrent infections may require excision of the duct areolar complex. Breast cysts are considered non-proliferative breast diseases. They are fluid-filled epithelial lined cavities in the breast tissue, influenced by ovarian hormones. They mostly occur in women over age 35, and the incidence goes up with age. You can confirm the diagnosis with ultrasound and aspiration. Follow-up imaging should be obtained to make sure that there is resolution of the disease. A galactocele is a breast cyst filled with milk, and it occurs in breastfeeding women. Treatment usually involves aspiration or incision and drainage. Now, fibrocystic breast diseases are also considered nonproliferative. There are many different subtypes. It is a very heterogeneous group. Generally, you only need to resect the areas that have suspicious calcifications. Usually, it presents as breast pain and irregular breast tissue that can vary with the hormonal cycle. So sometimes the patients will note lumpy, bumpy breast tissue, and sometimes some nipple discharge, yellow to brown. All these concerns should be taken seriously, and a good history and complete physical exam, including a good breast exam, should be performed. A fibroadenoma is considered a proliferative breast disease, but without atypia. They are benign solid tumors composed of stromal and epithelial elements. They're the most common tumor in the breast that we see in women under age 30. They usually present as firm, rubbery, well circumscribed masses that are freely mobile. They may have coarse calcifications at times. Usually, these are in popcorn configuration. We call them popcorn lesions. And if the patient is less than age 40, we usually want to just start with the clinical exam. If we feel something that's firm, rubbery, and mobile, we want to make sure we evaluate that with an ultrasound and mammogram. And a lot of times, doing a core needle biopsy on this to get our definitive diagnosis is the way to go. If the patient is over age 40, and some sources will tell you age 30 as a reference, you really want to consider an excisional biopsy to confirm the diagnoses. It's important to talk about the risk with the patient and part of what we call shared decision making. Also, note these fibroadenomas can grow to large sizes, and a core biopsy may give us a particular architecture diagnosis. But it's important to have the entire area excised because you don't want to miss something like a Phyllodes tumor. That should also be in the differential, especially for large fibroadenomas. Introductal papillomas. These are proliferative diseases, usually without atypia. They are polyps of the breast ducts, most often located close to the areola. They typically present with bloody nipple discharge. In fact, they are the most common cause of bloody nipple discharge of the breast. And they're not associated with a significant increased risk of breast cancer. However, there is a slight increase in the relative risk. The diagnosis is made with contrast ductogram, then needle localization, classically. However, often MRI is used to identify areas of concern when we talk about nipple discharge. Treatment is excision of the involved duct and papilloma. Atypical lesions, proliferative. Now, these lesions include atypical ductal hyperplasia and atypical lobular hyperplasia. Atypical ductal hyperplasia is proliferation of uniform epithelial cells filling the involved duct. The diagnosis is usually made with core needle biopsy, and the treatment of these is excisional biopsy. There is a risk of upgrade to DCIS or invasive breast cancer, sometimes in 10 to 20% of cases. Atypical lobular hyperplasia is proliferation of monomorphic cells involving the lobule. The diagnosis is made by core needle biopsy, and usually the treatment is multifaceted. It can be done by close observation. You can excise it if it's discordant, and discordant means that what was seen on biopsy and what was seen on imaging don't quite match, or there's lack of agreement. Or if there's limited sampling on the core biopsy, this will usually be reported by the radiologist or the pathologist. And if other high risk lesions are present, you want to really take that into account and maybe lean towards excision. These lesions are considered high risk because they are associated with the slight increase in the patient's future risk of developing breast cancer. So I've included this risk of lesion categories and risk associated with breast cancer because I think it's important for us to understand some of these benign lesions and see what their risk may be. And we can also use that to counsel patients and help inform decision making when it comes to observation versus excision. So non-proliferative diseases have an aggregate relative risk of future breast cancer with a 95% confidence interval of about 1.17. That's close to 1, which means that their relative risk is not significantly higher. Lesions that are proliferative without atypia, such as fibroadenomas, introductal papillomas, sclerosing adenosis, and radial scar, have a 1.76 relative risk of future breast cancer, which means that that risk is a little bit more significant than the non-proliferative. That means about 1.76 times more likely to develop breast cancer. Atypical hyperplasia, such as ductal or lobular, does have a 3.93 or almost 4 times the relative risk of development of future breast cancer. So when we talk particularly about ductal hyperplasia, it's important that we understand this, and we usually urge the patient to get an excision because of this. Lobular carcinoma in situ, which we'll talk about in future slides, is associated with the significantly increased risk of future breast cancer, and that's why it's always excised. It's actually considered stage 0 breast cancer, according to NCCN guidelines. So we'll talk about that in some upcoming slides. When we talk about some other diseases in the breast, we have Poland syndrome and Mondor's disease. Poland syndrome is really hypoplasia of the chest wall and is usually a congenital disorder. A lot of times the patients have amastia or no pectoralis muscle, and sometimes hypoplastic shoulder development as well. Mondor's disease is superficial thrombophlebitis of the breast. Patients will present with a cord-like structure on exam, and usually it's associated with trauma or other strenuous activity. A lot of times you'll have patients who've been working out or who've pulled muscles and really overdid it in a workout sometimes. Treatment usually is non-steroidal anti-inflammatory medication. Galactorrhea is the overproduction of milk, and it's caused by multiple different things, such as pituitary tumors, the use of oral contraceptive pills, cimetidine, TCAs. And really, the main focus is to treat the underlying cause by removing the offending agent or resecting the primary tumor. Gynecomastia is enlargement of the breast, and it's often seen in teenage boys. It's usually associated with marijuana use, spironolactone, and a lot of other medications too, including some of the ones that are associated with galactorrhea. It's usually idiopathic, and it usually will regress and go away on its own. But if it continues to persist, definitely resection is possible. Mastodynia is breast pain, and there are numerous causes of this, including trauma, infection, caffeine, nicotine, and different medications. The treatment is usually lifestyle changes, cessation of some of the offending agents like caffeine and smoking, oral contraceptives, NSAIDs, bromocriptine, or just treatment of the underlying cause. It can be cyclic or continuous. And really, when it's cyclic, we start to get concerned that this may be fibrocystic breast disease. And if it's continuous, it could be due to infectious or chemical causes such as medications. Treatment is usually made in those lifestyle modifications that we mentioned, such as avoiding caffeine, stopping smoking. The use of evening primrose oil and vitamin E also are effective. Now let's talk about malignant disease. Breast cancer. Now, breast cancer affects 1 in 8 women in their lifetime. So that's 12.5% lifetime risk of developing breast cancer. The screening that's been done decreases mortality by at least 25% in most studies, and a lot of times a lot more than this. 10% of breast cancer patients have a negative mammogram. There are certain cancers that can't be seen on mammogram because they lack calcifications. Screening recommendations are women over age 40 should have a mammogram at least every 2 years, then yearly after age 50. There are a lot of recommendations from different bodies that look at data, such as the USPTF, the American Cancer Society, and a lot of other large organizations that make recommendations for screening. Now, these can be a little bit confusing. We also use a term called SDM, which is shared decision making, where we talk with the patient and we kind of gauge their risk factors and some of their past medical history and some of the things that may put them at increased risk. Generally, it's well accepted that age 40 is the age to start screening mammograms. And most insurance companies will pay for it yearly. So generally, we recommend minimally every 2 years, ideally every year, starting at age 40. High risk patients, you start to screen them 10 years younger than the age of the relative at diagnosis. So, for example, if someone had a mother who was diagnosed at age 46 with breast cancer, then the patient should start screening mammography at age 36. Hereditary genes such as BRCA1 and BRCA2 are very important in breast cancer as well. BRCA1 has approximately a 55 to 72% risk of lifetime female breast cancer and 39 to 44% risk of ovarian cancer. BRCA2 is similar with a 45 to 69% risk of lifetime female breast cancer and an 11 to 17% risk of ovarian cancer. This information is from the National Cancer Institute and it's current as of November 2021. Globally, breast cancer is the second most frequently diagnosed malignancy just behind lung cancer. This is the most recent data available from the NIH at cancer.gov, and it is estimated that in 2021 there will be over 281,000 new cancer cases. Over the last almost 30 years, the cancer death rate has been decreasing while the incidence has held steady. Factoring all stages, the 5 year relative survival rate of breast cancer is 90.3%. There are multiple risk factors for breast cancer, and they include the following that you see on this chart here. However, we are finding more and more risk factors every day in clinical medicine, and these should just be considered as a guide. In younger patients, usually those under age 30, when you want to work up a breast mass, you want to start with a good history and physical. Any question that you get, always start with a good history and physical. That will really get you in the right direction. Now, after that, you want to do an ultrasound and a core needle biopsy of the breast lesion. And if you have any indeterminate findings or any concerns, you absolutely can get a mammogram. Mammogram interpretation can be difficult in these patients because young patients tend to have a very dense breast tissue. Biopsy types most commonly used by radiology is a core needle biopsy, and that'll give us the architecture. Fine needle aspiration is not commonly as used anymore when trying to get actual tissue of the breast lesion. Patients who are about 30 to 40 years old, we talk about shared decision making. There's a combination of ultrasound and mammography that's used in these patients. In fact, mammogram and ultrasound usually get performed together with any questionable lesion. Patients who are greater than 40 years old, again, start with the history and physical exam and go to a bilateral mammogram. We can add an ultrasound and we can also add an MRI if needed. Core needle biopsy. If the core needle biopsy is indeterminate or non-diagnostic, we recommend excisional biopsy because that means something is not concordant with the imaging or it's not agreeing. An excisional biopsy should be performed when there are indeterminate biopsy results or there's discordance. What that means is the core needle biopsy results and the imaging don't match or they don't agree. So whenever there's a question, you should do an excisional biopsy. When a solid mass is suspected, when there's bloody cystic fluid, or there's a recurrent or complex cyst that's just not going away, it's important to excise that and see what may be underlying it. Breast cancer imaging usually focuses on three modalities: mammogram, ultrasound or sonography, and MRI, as you can see the representative image down here. The BIRAD system is a breast imaging reporting and data system. It's a standardized system for quality reporting in mammography, ultrasound, and MRI imaging. It gives a recommendation for each classification, which is also very helpful for clinicians. It ranges from category 0 to category 6, category 0 being need additional imaging evaluation. Basically, it's an indeterminate mammogram, MRI, or ultrasound. 1 is negative, which means that the patient really just needs to continue annual follow-up imaging. Two means it's a benign, non-cancerous finding, which also means the patient can continue with annual screening. A BI-RADS 3 is probably benign, and the patient should get a short interval follow-up, like a 6-month mammogram or ultrasound. Four is suspicious abnormality, and a biopsy is required. And five is highly suggestive of malignancy, and that requires a biopsy. Six is a known biopsy proven area that may be getting imaged later on in the course. Here is an image of the probability of malignancy. As you can see, the higher the BI-RADS number, the more suspicious the lesion is, but also the higher the probability of malignancy. So it's really important to pay attention to your BI-RADS 4s and 5s because those require biopsies. Your BI-RADS 3 requires short interval imaging, usually with a 6-month mammogram or ultrasound. And your BI-RADS 1 and 2s are the ones that you can go back to annual screening. I'm really reiterating this because it's important to be able to identify what should be done with your patients based on their mammography, ultrasounds, or MRI, regardless of what specialty you go into. In situ lesions. LCIS, or lobular carcinoma in situ, is a proliferative lesion with atypia, and it's a marker for breast cancer risk. It's not considered a cancer itself. It has an 11.3% risk of cancer in the breast at 10 years and a 19.8% risk of breast cancer at 20 years. The risk is increased in both breasts. So you can have a lesion in one breast, but it also increases your chance of developing breast cancer in the other breast. It's more likely to develop into a ductal carcinoma, however. Diagnosis is by mammography and ultrasound, and often it's missed on mammography because there are no calcifications with this disease usually. It tends to be an incidental finding and can be multifocal in nature. The treatment involves observation, tamoxifen, or bilateral prophylactic mastectomy. Usually, no axillary lymph node dissection is warranted. DCIS, or ductal carcinoma in situ, is considered stage 0 non invasive breast cancer. Malignant cells of the ductal epithelium that do not invade the basement membrane define this disease. Mammography, ultrasound, and MRI are imaging modalities of choice. They will reveal a cluster of calcifications. DCIS, or ductal carcinoma in situ, is considered stage 0 non invasive breast cancer. They consist of malignant cells of ductal epithelium that do not invade the basement membrane. You diagnose it with mammogram, ultrasound, or MRI, and usually you'll see a cluster of calcifications. Treatment of DCIS includes lumpectomy and radiation. We consider this breast conservation therapy, or BCT. However, if the patient undergoes a simple or total mastectomy, we usually want to consider a sentinel lymph node biopsy on these patients because the anatomical changes to the nodal basin may be altered when you want to come back and do a sentinel lymph node biopsy. Types of invasive breast cancer. Invasive ductal carcinoma is the most common type of invasive carcinoma of the breast. Microscopically, it appears as cords and nests of tumor cells with varying amounts of gland formation. The fibrous response in the parenchyma can lead to the palpation of a mass. Invasive lobular carcinoma is often not identified on mammography because it usually does not have calcifications. It does increase the risk of cancer in the contralateral breast. Now, looking at those histopathological types of breast cancer again, you can see invasive is the most common, followed by invasive lobular carcinoma. Now, let's discuss the types of breast surgery. Different terms for breast conservation therapy include lumpectomy, partial mastectomy, quadrantectomy, and more. Breast conservation therapy is a lumpectomy with radiation. The lumpectomy is when we remove the target tissue with adequate margins. It may also be called a partial mastectomy at times, so be ready to interchange those terms. A total or simple mastectomy is where we remove the entire breast parenchyma, the nipple, and the skin, and some lymphatic tissue included in the anatomical borders of the breast. As you can see in this image, the tumor is located here, and the mastectomy is taking the whole breast. Down here, you can see a patient who has had two simple mastectomies with what we consider flat closures, so no reconstruction. Nipple sparing mastectomy, or NSM, is where we remove the whole breast parenchyma but leave the nipple and skin envelope intact. It's an oncologically safe surgery. As you can see in this image here, her skin envelope is intact, but she has had flap reconstruction. A skin sparing mastectomy, or SSM, is where we remove the breast parenchyma and nipple areola complex. We do leave some skin. A modified radical mastectomy is where we remove the whole breast parenchyma, the fascia, and level 1 and 2 axillary nodes, so a complete axillary dissection. This is not performed as commonly, but is still a very viable surgical procedure and is indicated as a primary modality for certain types of cancers. Radical mastectomy takes the pectoralis major and the minor and the level 1 and 2 and 3 lymph nodes. It's rarely performed. Contraindications to breast conservation therapy: multicentric disease. Multicentric is two or more lesions in different quadrants of the breast, versus multifocal, which is two or more lesions in the same quadrant of the breast. An inability to obtain clear margins despite resection, so that's no tumor on ink for invasive carcinoma, and 2 millimeters for DCIS. Diffuse malignant calcification, and an inability to undergo radiation, such as pregnancy. This is a relative contraindication. Sentinel lymph node biopsy. Indications for sentinel lymph node biopsy include invasive carcinoma, T1 to T3 disease, high grade DCIS. Contraindications to sentinel lymph node biopsy mainly include a clinically positive node. If you have these clinically positive nodes, you really need to be thinking axillary dissection. Axillary lymph node dissection. We take level 1 and level 2 nodes during the dissection, and we usually want a minimum of 10 lymph nodes. This is what has been found to be prognostic. Complications include infection, lymphedema, and lymphangiosarcoma, particularly Stewart-Trevi syndrome. Borders of the axillary dissection are once again reviewed with you here. Thank you very much for watching.